So, my dear candidates, I discussed many tips on how I will conduct my session, though it was not recorded. Who missed this session? My same advice will be daily. How to do practice and how to make sure the answer will be correct in our exam. It is our aim. So, Bismillah Rahman Rahim, I'm starting my session from the cardiology. Cardiology session is the session which will carry from the emergency medicine question and cardiology session question. Because question will be mixed in exam. Emergency question will be from the hypoxia, ABG interpretation, and from the cardiology, respiratory medicine. So I'll cover those emergency medicine, cardiology, respiratory medicine together because this question will carry more than 10 questions. My exam, my ABG interpretation question was more than 5 questions. So you have to know ABG interpretation more strongly. I'll take session soon after cardiology session, after ECG session, and with respiratory medicine. So, and emergency medicine, another question, another topic. So all candidates make sure, yeah ma'am, I am clear now. Now what will be the answer, like that, if any confusion, because recall always incomplete, recall many times could be complete. So make sure is it complete or not, because in exam all will be clear if you have clear knowledge. If you know it's a type 1 respiratory failure, so you never mark intubation. You have to make sure it's a type 2 respiratory failure. If you know it's a acute left ventricular failure, so you have to mark first furosemide because decrease the pulmonary edema. You will not mark BiPAP or non-invasive ventilation. That is the way. That is the technique. We have to make sure our correct the answer. So I'm starting my session from the acute coronary syndrome, and nowadays ECG question are coming. Inferior MI question, myocardial infarction, atrial fibrillation question, and how we will manage. Kindly mute the mic. I strongly advise for all of the candidates when you enter my session. Okay. So acute coronary syndrome, a patient comes to your hospital with chest pain. You are a doctor of emergency medicine. I will make sure everyone should be mute the mic, and when I will say that unmute the mic, Dr. Priya or Dr. Sajia, so you can unmute the mic. That's it. So we have to make sure that the ECG, then we have to do as we are emergency doctor. It's an emergency question. A patient comes to your hospital with chest pain, what you will do next? Next means now you what you will do. So either ECG or troponin I. I have to do first ECG, then troponin I. Patient, if they give ABG interpretation, hypoxia, carbon dioxide, hypercapnia, what is the ABG status? So we have to make sure what is the patient condition. This full cardiology question, make sure either it is a cardiology part or emergency part. So they will ask you even after passing DHA, whatever the exam, you have to take ALS, BLS certificate also. So make sure you clear conception, my dear candidates, all, because as I am cardiologist, so make sure all the clear conception. So after chest pain, we have to do ECG. Then troponin I. If it is not elevated, ST elevation not upright, it's depression or T inversion or pathological Q wave, but troponin I high. Troponin I high, but ST depression or T inversion, and patient have severe chest pain, but it's not elevation. So it's a non-ST elevated MI. So we have to start ACS management soon. Question will ask what is the definitive test you will do, what is the management you will do. Don't be confused, because why? If there's an initial, do ECG. If there's a definitive test means what? Anyone? I ask. What is the definitive? Dr. Fatima is here.
Yes, ma'am, I'm here.
Okay. Yeah. Actually, he has two Fatima. Fatima, actually, how I can remember, I don't know. Two Fatima is here. So anyone can change the name. It will be nice to me that Fatima 1 or Fatima 2 Fatima is here. I know. Yeah.
Yeah, you can say for Fatima 1 from Pakistan.
Okay. And another doctor is for the heart candidates, Fatima 2. I saved the name like that way.
Yeah. Now I am in UAE.
UAE, okay. Fatima UAE for the heart candidates, Fatima Pakistan for the DHA candidates. As far I remember.
Yes, ma'am. Yes.
Yeah. So Dr. Fatima in Pakistan, if a patient comes to your hospital with chest pain,
Yes.
you are a doctor of emergency,
Okay.
and patient sweating, vomiting, ongoing. What is the definitive test you will do? And you saw already lab value come, troponin I high, ST depression in V1 to V6. I said, what is the specific or definitive investigation you will do? Tell me. I didn't give you any option because I don't want to be confused. Just tell, ma'am, this is the definitive test.
Like the patient is coming with the chest pain and he is having the vomit and vomit now only.
Vomit, sweating, and troponin I higher, but ECG showed ST depression in V1 to V6. I asked, what is the definitive test or specific test you will do for this patient?
Ma'am, the ECG, I guess.
You
First.
already show ECG showed ST depression. You already do troponin I, which is raised. So what is your diagnosis? Tell me. I said two things. ECG value, I said ST depression. I said troponin I, already done. It's raised. So what is your diagnosis?
Diagnosis would be angina, unstable.
No, dear. So now don't kneel down. Are you here? I will discuss.
Yeah.
No issue.
Yeah. Cardiac
Yeah,
enzymes. Cardiac enzymes. We need to check the cardiac enzymes.
I said, don't kneel down, that troponin I high means troponin I leaked. I said ST depression V1 to V6, already you done ECG. So what is the diagnosis? I'll ask intermittent because these are the exam question. We have to make sure the clearance, the conception.
Angiography.
It is answer is angiography, but anyone can tell me the diagnosis of this patient?
Non-ST elevation MI.
Good, excellent. Yes, excellent. Because why, Dr. Kutia? Just unmute.
Because the ECG findings are the ST is depression plus T inversion, and the other option I forgot about it, but the main
What about cardiac enzymes?
I said it's raised, doctor.
It's raised.
I said it's raised. Okay.
The ECG indicates is non-ST elevation MI.
But even Dr. Kusse is discussing it with me. I said just unmute my mic when I say the name, so they will discuss it with me. I said troponin I high means what? Non-ST elevated MI. Troponin I leak. If troponin I didn't raise but ST depressed, What does it mean? Anyone? Any candidate? Dr. Pallavi raised hand. If troponin didn't raise, but ST depression, what does it mean?
Acute coronary syndrome.
Unstable angina.
It's excellent. It's excellent. Excellent. It's unstable angina. So thanks, all my candidates. Excellent. But what we have to do? Kind of mute the mic. Just make sure when we'll say the unmute the mic and you will unmute the mic. Neither it will cause echo and all will be the interrupted our discussion. So best one by one, not all. Okay. So one by one we will discuss. One by many question we will discuss. We inshallah will clear all our conception, and we have to make sure I am clear in that because this question they will ask step by step. One step troponin I high, another question ST depression but troponin I normal. So one question, which one troponin I raise, it means it is non-ST elevated MI. Another question, which cause troponin I normal but ST depression all leads, so it means unstable angina. So we have to make sure what they say. We don't need to be hurry. We will be cool because we have to make sure the correct. I know everyone know everything, but we have to make sure either it's unstable angina or it's non-ST elevated because they will give twisting. And management will be the non-ST elevated MI and ST elevated MI will be the more likely same. Still now ongoing the non-ST elevated MI angina discussion now. ST elevation. ST elevation MI. ST elevation MI is a clinical scenario that our ST will be elevated. It's according to the ECG leads. So we have to make sure which are the leads goes towards the infraction. Is it a V1 to V6 means what? Anterior. V1 to V4 means what? Anteroseptal. 2, 3 AVF means what? Inferior. So we have to make sure and we have to remember it strongly. Okay. Then after ST elevation, no need to do any troponin I. We are the emergency doctors. Make sure it's ST elevation, ongoing chest pain. The question they ask in the exam, if patient in now I will discuss one by one. If anyone do wrong, and I will ask another candidates and they'll make sure and discussion because all no need to be unmute, but it will cause echo. So Dr. Ramzan is here. Dr. Ramzan.
Yes, ma'am. Yes, ma'am.
Okay. So Dr. Ramzan, you are emergency doctor and you find out a 57-year-old gentleman come to your hospital. 57-year-old gentleman come to your hospital with chest pain. And
Okay,
you done ECG, ECG showed 2, 3 AVF ST elevation. And you asked how long this chest pain you started. And patient said, sir, I have this chest pain only 4 hours. Only 4 hours.
Okay, ma'am.
My question to you, what is your diagnosis? Second, how you will manage this case? Tell me, step by step.
Ma'am, inferior wall MI.
Okay, excellent. This diagnosis is done. Second, how you will manage the duration? I said 4 hours. I didn't say any option. You are the emergency doctor. Tell me how you will manage this case.
Percutaneous intervention.
Excellent. Percutaneous intervention is called primary PCI. Primary intervention because it's our door to needle period. Door to needle period is 4 hours. Door to needle period. But I said in your exam question, you are not a tertiary hospital, and in around there is no hospital to do any PTC. How you will manage? This is another recall. Tell me.
Thrombolytics.
Thrombolysis. Excellent. So you will do this thrombolysis because this is the period and we can do thrombolysis, right, Dr.
Okay.
Ramzan?
Yes,
But
ma'am.
another recent question. Patient has hemorrhagic stroke 2 months back. What you will do right now?
Then we will treat with aspirin.
And aspirin you will give it loading
statin,
then.
statins.
Okay, but you didn't get your answer. Still, I'm waiting for your answer. Aspirin, statin, but 2-3 AV waste up. You can't thrombolize. You giving the loading aspirin, clopidogrel, but what is your management? Yeah, angiography PTC is not in your center. You are not this center doctor. You what? How you'll manage? You have to start low molecular weight heparin.
Yes,
You
ma'am.
have to
I will
start
do that.
low molecular weight heparin, enoxaparin or fondaparin, whatever in our hand. We have to make sure, right? Dr.
Yes,
Ramzan,
ma'am.
clear?
Yes, ma'am. Yes, ma'am.
So excellent, Dr. Ramzan, done that. The how to diagnose step by step. Because 3 questions I discussed from the still elevated MI, that if patient come to my hospital within the period of the window, how I will manage. Then if my hospital is not a tertiary hospital, away from the main zone, how I will manage. Then if patient has history of any contraindication, any surgery, any stroke, how I will manage. Clear? All clear, I feel. Okay, and we'll discuss more question later. So thank you, Dr. Ranjan, for your nice performance. So acute coronary syndrome, we have to do the ECG. Yes, and we already discussed the ST elevated MI, non-ST elevated MI, and stable angina. So presentation, we know very well the chest pain, along with if there is any radiation, if there is any jaw tightness, if there is, kindly mute, okay? You can't do the make the echo by ourselves, okay? So we have to know the presentation, though we know very well this heaviness, constricting care, okay? That's the point we have to know. But if any risk factor or comorbidity, what are that? Patient long-term diabetic patient. Okay. Unmodifiable risk factor. Unmodifiable. You can't do modify means what? A 45-year young man come to your hospital, no smoking history, nothing, but family history positive. Come to your hospital with MI. That means it's genetic predisposition here. Genetic predisposition here, only family, and these are the we have to make sure. Unmodifiable risk factor. Male gender increasing risk, even question twisting always younger age valued by family history. Don't be mismatched. Modifiable risk factors, smoking, common, diabetes mellitus, hypertension, hypercholesteremia, and obesity. These are the modifiable if anyone have uncontrolled diabetes. If you wanna have a BMI high, these are the causing atherosclerotic change in the blood channel. So we have to make sure to decrease this atherosclerosis. Yes, I can't do modify our age, I can't do modify our genetic predisposition, I can't do, but I can do the modification of my sugar level, I can do modification of my smoking level, I can do modification of my cholesterol level by taking diet, by dietary modification. So my dear candidate, always I have to make sure what they are giving the clue of my question. So read the option first. Is that modifiable lifestyle? Is being starting? Okay. Is the family history any modification? So what they are asking? So make sure it. Okay. So I said ECG interpretation. I will discuss tomorrow, inshallah. ECG interpretation. I will take a session because common ECG they are giving nowadays VTS, VT atrial fibrillation. Commonly the AMI, ECG, inferior AMI, complete heart block, secondary heart block. So we have to make sure. I will never give a long ECG class. Just I have to make sure gist we have to know, and we have to make sure the correct answer. So ST elevation AMI. Okay. The lead already I discussed this lead. Inferior wall MI means 2-3 AVA, which indicate right coronary artery. Question they ask 2-3 AVA ST elevation, which means what are the coronary artery affected, or in which artery you will do primary coronary intervention or PCI. Okay. Second, lateral MI. It means one AVL V5 VC even. They will not give V5 VC's value, only one AVL value. One AVL value means only it's a high, it can make a short note with my discussion. One AVL means high lateral MI. If it associated with V5 basis, it means it's a lateral MI. My dear candidates, make sure all our conception clear. So anterior or anteroseptal. I said V1 to V6, whatever they have written here, make sure V1 to V6 is the anterior MI, V1 to V4 is anteroseptal, and it indicates left anterior ascending, left anterior descending artery. Anterolateral means one AVL V4, V5, 6. This is the exam question anterolateral MI, so you have to make sure it's a anterolateral, but don't be confused by anteroseptal and anterior. Anterior means always one AVL with V1 to V6, and anterior septal means V1 to V4. And the arteries indication with ECG interpretation. Here is inferior MI. You can see 2, 3 AVF ST elevation. You can see very nicely. So inferior MI means it right coronary artery occlusion, and we have to do emergency coronary angiography if setup is here in my level. So already I discussed non-ST elevated MI, ST elevated MI, all are the exam question. Unstable angina mean what? Chest pain even in rest. Dyspnea, chest pain even in rest. Stable angina means if you take it goes down, it remove, it resolve. Non-ST elevated MI means troponin I elevated and ECG, ST depression and ST inversion. And ST elevated MI I already discussed. As far as I remember, before my session, one question my candidates do asking many questions regarding the LBB picture and they are marking thrombolysis. Never do it, never. New LBB remark anterior MI, no. Because why? Don't be confused by ST elevation V1 to V6 with 1 AVL by anterior, cause LBB could be unstable angina if troponin I didn't leak. According to the presentation, I have to correlate with my option and my presentation what they are asking. So onset new LBB, it could be MI, but if troponin I didn't leak, though they keep it in ST elevated. But make sure in prometric exam you have to correlate with your option. I will do thrombolysis in new onset LBB when typical clinical presentation, radiating chest pain, and now within 4 hours come to your hospital, troponin I high, new onset LBB, all information you need to do thrombolysis. Don't be haphazard. All are the point we have to know strongly. My strong point, every candidate here, they know all, but you have to catch correct answer, what they are saying. It is our point, and the course is only one thing that you have to correct your answer. So ST elevation, if they didn't give new onset LBV, if typical clinical presentation like only 4-hour chest pain without any contraindication, troponin I higher, all information they'll give. So make sure we have to can thrombolysis. But new onset LBV, but troponin I normal. How you can do thrombolysis? You can't do. It is not MI. It's unstable angina ongoing. It's thrombus ongoing on progression. So we have to make sure, yeah, we can start a heparin. That's it. Okay. So Mona, common question exam, my heart candidates, my DHA and Prometheus, all candidates remember. Even in Viva, they ask regarding the Mona. Every candidate make sure after passing in ALS course along with the Viva question, because they'll ask. So Mona, morphine, oxygen nitrate, aspirin load in 300 milligram to decrease the pain, to decrease the vasoconstriction of the cardiac coronary arteries, cardiac muscle constriction. So Mona is the acute setting management in the emergency medicine. Without any contraindication, We can do thrombolysis, but if it is non-ST, we can do the enoxaparin. But make sure, another point is strongly commonly asking question in the exam is, if patient is CKD patient, non-ST elevated MI, direct question in the exam, we have to do the, we have to give the unfractioned heparin. We have to give the unfractioned heparin if just only one point they said, patient known case of CKD. So we can't give enoxaparin. We have to make sure it's unfractioned heparin. The exam candidates, few exam candidates, before my ending my course, their exam very near. So make sure. Many important questions I'm discussing today, topic wise and management, make sure them. Okay. And PDF will be given after the session or after the tomorrow session. Okay. So if the patient presents within 12 hours, I said this Parkinson's corner intervention according to the gold standard, according to the tertiary hospital, they'll give every value. Okay. And even if they don't give value, see the option. If the option present primary PCI, that means okay, my patient is now a tertiary hospital. That's why option in primary or Parkinson's corner intervention and patient present to my hospital within 4 hours. My dear, can just correlate with option and question. If option didn't persist, PTCA, only thrombolysis, enoxaparin, heparin, whatever the question, but no, only angiography, I can't do because patient is not a tertiary hospital. Within 6 hours, but ST didn't elevate it, make sure the enoxaparin, that's it. If ST elevated, make sure thrombolysis, even if they are not a tertiary hospital. So this is the point. Chronic long-term MI means what? Chronic long-term means it could be the chronic stable angina still didn't troponin I leak. But if troponin I leaked, means a patient come to the hospital, ma'am, I have the MI 12 months back. Now I'm feeling again chest pain. I can't do any work. It's mean post MI angina. This word could be new, but remember it's the post MI angina. Why? This patient didn't get or didn't take specific management like PTCA, coronary intervention, or angiography. They didn't do. That's why ongoing chest pain. So, though patient on this medication, aspirin, ticagrelor, beta blocker, AC inhibitor, these drugs, just strongly remember, my dear candidates, statin all over the life, We have to make sure the aspirin, beta blocker to decrease the cardiac rate and vasodilation of the coronary arteries. AC inhibitor has many roles. If patient is not CKD patient, this AC inhibitor increase cardiac safety, decrease cardiac mortality. So AC inhibitor have many roles. If patient has diabetes, so it's excellent drug. I have to choose ACE inhibitor. You are asking, ma'am, patient is CKD patient, what I will do? Okay, you can go towards the angiotensin receptor inhibitor, ARB, losartan, valsartan. You have to make sure what are the patient of mine present to my hospital. Angina, okay. MI, is it patient DM or not? If DM, excellent drug AC inhibitor to maintain cardiac safety. Okay. So I hope all clear regarding the long-term management. No one can do any wrong. Or you can remember this ABCS. These are the protocol: aspirin, AC inhibitor, beta blocker. Okay. So non-elevated and unstable angina management I discussed regarding the enoxaparin, dalteparin, and fondaparinus, and we have to make sure the unfractioned heparin in case of CKD patient. Okay. So I will ask question now. This is the, though I said we know very well, but discussion very important. Dr. Aisha is here. Okay. Dr. Nandini.
Yes, ma'am.
Okay. Dr. Nandini, read example 1.
Yeah, a patient presents with acute chest pain relating to jaw and shoulder, plus other features suggesting ischemic heart disease. However, without ST elevation on ECG, what do you do next? Uh, for this, we will, because it's a presentation of basically angina, we'll be going for biomarkers like tropi.
If tropoid didn't
And
high,
if
tropoid
tropi is
negative.
not high, okay, tropi is negative. We can go for a gold standard for this. We can go for angiography.
No, I said step by step. You done troponin 9. If say what is the diagnosis? If negative,
If negative, it's unstable. It's unstable angina.
if positive,
If
if the
positive, it's NSTEMI,
non-ST,
non-ST elevation on my.
not
Yes,
ST.
yes,
It's the
ma'am.
non-ST. So
Yes,
it's a,
ma'am.
I
It's
said
non.
okay. It's a non-ST elevated MI. So how you will manage? How you will manage?
For non-ST elevation, we can go for the drugs like morphine, oxygen.
Monotherapy. Mona.
Yes, monotherapy. Yes, ma'am.
Then
Plus, we can go. We can go for unfractional heparin, like
why?
enoxaparin.
Why unfraction? I said one point. That's it is the point I would make to discussion. Why unfraction? Is that patient is CKD patient?
No, ma'am.
So what type of heparin patient will get?
Low molecular weight heparin.
Clear, doctor? You have to make sure. We have to start enoxaparin, no low molecular heparin. There's no indication for no, unfraction because patient is not a CKD patient, right?
Okay, ma'am.
Clear. Nandini, doctor, right?
Yes, ma'am.
I'm discussing with Dr. Nandini. Okay. Clear. Clear the question.
Okay, ma'am.
Okay. You can mute the mic. So give low molecular heparin or fondaparinase. So I'm discussing with Dr. Nandini. Though Dr. Nandini tried the best and she nicely done the example. And it's really nice that we have to make sure that low molecular heparin, there's no option you get a CKD. So we can't do unfraction heparin, though they'll give this option unfraction low molecular heparin. Even they give only heparin. So you may ask, ma'am, heparin, unfraction heparin, low molecular heparin, what's the difference? Many difference. Every heparin have difference. You can't give without low molecular heparin, only heparin, because only heparin we use only PTC when we running. It's the only heparin. So don't do this. We have to make sure low molecular heparin. Even if any collection of question, they mark heparin, cross the question because it's a incomplete or wrong question. In exam, they didn't never give this kind of question. Non-stable MI, unstable angina, low molecular heparin, not only heparin. Unfraction heparin, only CKD patient. So, few question I discuss. So, from my platform, Dr. Rekha, if she is available, or Dr. Saba, Dr. Shasma.
Yes.
Excellent. Dr. Shazma, you will discuss. I think there's echo. You can mute the echo and you can discuss with me. It will be nice to me. Okay. So Dr. Shazma will discuss with me example 4. Start reading and I'll give the clue. What is the next they given?
A 59-year-old hypertensive patient presented to the emergency complaining of dull central chest pain for around 4 hours. His vitals are as follows: heart rate 99 beats per minute, blood pressure 155 by 95, respiratory rate of 21 beats per minute, oxygen saturation on room air is 97%, chest X-ray is normal, troponin level is pending. He was given IV morphine for his chest pain. The ECG is as follows.
So Dr. Shazma is here.
Yes, doctor.
Okay. So ECG showed T inversion in 2-3 AVF. T inversion. Question is chest pain ongoing. T inversion present. What does it suggest? And how you will manage?
It suggests inferior wall MI.
No, I said what is there any troponin I leaked? What does it mean? They said troponin level is spinning, right, Dr. Sajma?
Yes.
So how you will manage and what is your interpretation T inversion in 2-3 AVF?
As the pain duration is around 4 hours, so initial gold standard is for PCI will do. If it is not available, then we'll go through for the thrombolytics. But the initial gold standard is primary coronary intervention.
Dr. Sajma, I feel I'm taking session around 45 minutes. I said T inversion. Dr. Sajma, T inversion and T, because I have to make sure my all countries, if it's ongoing, that means they are not getting my point. T inversion 2-3 AVF and troponin I pending.
If T wave inversion, then we'll go with it will be non-ST segment elevation MI. Then we'll wait for the troponin. If it is normal, then it will be unstable angina, and if it is raised, then it is non-ST elevation MI.
How will manage? What will start?
We'll do the we'll go PCI, and then if PCI is not available, then we'll give the thrombolytics.
Okay, Dr. Sajma, you are in waiting area. Dr. Akin Siku, are you here? Akin Siku? Or Dr. Solomon is here. If you were able to talk with me, you can. Dr. Umer? Okay. Dr. Vizin? Dr. Vizin, anyone whose exam were in Dr. Vizin?
Hi.
Dr. Umer? Okay.
Hi.
So it's the Dr. Reza, right?
Yeah.
Okay. So Dr.
Can
Reza?
Can I answer?
Dr. Reza?
Yeah.
Are you here? Yeah.
Yes.
Reza, did you get my question? Did you get?
Yeah. Non-STEMI MI and inferior non-STEMI MI need to heparin, low molecular weight heparin, and RSR. And RSR.
Aspirin.
Aspirin, yeah.
Aspirin. You have to make sure your word aspirin. You have to make sure aspirin. So yeah. Dr. Sajma. Okay, thank you, Dr. Reza. You've done well. Dr. Sajma, are you here?
Yes, doctor. Yes.
You said angiography, gold standard. How you are coming here? Because patient is not a elevated MI. You have to make sure heparin first, right? You have to make sure heparin first.
Okay.
Then you can go to the angiography, whatever the things it says, it's tertiary hospital or no, whatever the thing. The thing is that I am not concerned regarding the angiography right now. I have to start low molecular heparin. My dear, every candidate, just make sure all are getting the point because these are the exam question what I am discussing right now. Dr. Reza nicely take this. Yeah, I have to make sure this enoxaparin and I have to make sure this aspirin, and then we can go towards the angiography and PT. It's a specific management. There's a question with Dr. Sajma ongoing. The ECG show Dr. Sajma C. Dr. Sajma. CST T inversion, only T inversion 2-3 AVF. See? So 2-3 AVF only T inversion means it's the myocardial ischemia on inferior wall. Inferior wall myocardial ischemia. Dr. Reza done that, I have to start from the perinosal low molecular heparin, but aspirin either they can give in the exam question or not, it doesn't matter. It is not our fact. My fact is that I have to make sure low molecular weight heparin. Clear, doctor?
Yes, doctor.
Okay, clear? Okay. One doctor makes, I'm in attention with the road, so I can say, okay, say, okay. The translator, I understand it. So these are the way we have to take our session. So this example 5 will do with me, Dr. Aisha Naim. Are you here? Dr. Aisha Naim or Dr. Saba, anyone? Or Sajma? Yes, already I discussed with Dr. Sajma is the best to discuss with. Dr. Tezamul, anyone? Still didn't discuss with me?
Hi.
Okay, Dr. Reza, we discussed. Just I give for slot for
Okay.
other candidates. I'll discuss with you. Okay.
Okay.
So Priscilla, Dr. Priscilla, Dr. Priscilla Rita.
Yes, Dr. Irene.
Okay.
Priscilla.
Yeah, Priscilla. So Priscilla, read example 5.
All right. A 61-year-old patient present to the A&E complaining of dull central chest pain for around 4 hours. His vitals are as follows. Heart rate 75, BP 135/85, respiratory 21, oxygen set on room air 97%. He was given IV morphine for his chest pain. The ECG is as follows.
So did you understand the ECG? If no, I'll tell the ECG finding. If you say, yeah, ma'am, I understand, so it's okay. Or I can say it's ECG what follows. Say, what is the diagnosis? Do you know? Or because I'll take the ECG, no issue. Do you know the ECG finding?
Yes, it's a STEMI.
STME anterior lead, right?
Right.
Say what is the next step of management?
So since his STEMI, gold standard is PCI, and because it's within 4 hours.
So cost within 4 hours. Excellent. So excellent. Dr. Sajma take the see the difference of the non-ST and ST. Within 4 hours, patient come to my hospital. I'll do the PTCA, primary coronary intervention, emergency coronary angiography. So two excellent, Dr. Priscilla, you done excellent. So two question I discussed, non-ST, ST. I have to make sure what are the ECG finding. Will I do the coronary angiography emergency base, or I will start the fondaparinose or low molecular heparin? I feel all are clear. Okay. So these are the way of the question we will face in the exam. Now cardiac tamponade, very important question. Many question I discuss and many question are mismatched. So see, cardiac tamponade means what? Pericardial fluid under pressure. So the triad. As far I remember, if you can just ask me personally regarding the muffled harsh sound, is it tamponade or is it like that efficient or something like that? I forget the question and asking me personally what is it. Just remember muffled harsh sound only for never pneumothorax, never hemothorax. There's only one thing that reflect cardiac tamponade. So cardiac tamponade means yes, pleural pericardial fluid accumulation and it reverses hypertension, muffled heart sound, raise high GVP. But don't be confused with acute left ventricular failure. Left ventricular failure reveals, my dear, can you try to remember my words? Left ventricular failure reveals crackles on pleural cavity or lungs. If you do auscultation in the lungs, it reveals crackles. So make sure it crackles on auscultation of the extent. So it's the LVF, but if they give muffled heart sound, it means it is tamponade. Question from the hemothorax, pneumothorax, tamponade commonly. So we have to make sure I'm clear on that. So they will give a chest X-ray, they will give the tamponade picture. So I have to make sure it. So cardiac tamponade picture, dyspnea, pulsus paradox. This is very important. Remember for the tamponade. So how you can remember? I always say TPP or PT. You can remember that way. That means pericardial tamponade associated with pulsus paradoxus. Okay. So pulsus paradoxus, high GVP, hypotension, which goes towards the cardiac tamponade, and I have to make sure it could be the after MI. Like my dear candidates, every candidates listen my word very carefully because these are the exam question. Either patient chest pain like inflammatory means pericarditis. It is one of the cause for the pericardial effusion. So pericarditis, make sure, is it pericarditis after the devular effusion or after MI? After MI, after pericarditis, whatever the cause, okay, we have to do pericardiocentesis even after trauma. More likely exam question after trauma goes towards the tension pneumothorax, but make sure what they were said. Muffled heart sound or diminished breath sound. Okay, so these are the point we have to make sure what they are trying to say. If we do everyday practice, but I can't get the question, it means I'm not getting the exact question. I can't correct this question in my exam. No benefit to everyday solving this kind of action. I have to make sure I'm clear on this knowledge. Is it pericardial tamponade? Is it pericardial effusion? Is it tension pneumothorax? Is it pleural effusion? What does it mean? So words, information, correlation, everything is very important. So my dear candidates, enlarged globular heart shadow, even if they give this quiz, excellent is for the cardiac tamponade. For the pericardial effusion, we have to do the echocardiography to measure the tamponade, measure the pressure of cardiac tamponade, and we have to do urgent pericardiocentesis. Okay, so this globular shaped heart shadow, enough to remark it is a water bottle sign or pericardial effusion. So management, they ask or they give this kind of picture my heart candidates. Remember pictures very well, or you can practice by doing this panelized or by doing the Google enough for passing. They like very much the imaging. So whatever the panel given those images enough to read those, and you can Google them. So cardiac tamponade, oxygenation, ventilation step by step, and you can start the normal saline and pericardiocentesis. It is the fact. Actually, who are practicing in critical care as I am practicing the cardiology, so we have to make sure patient vital stability. So you can say, ma'am, why normal saline? Cardiac tamponade itself develop hypotension. That is the point we have to make sure normal saline, and immediately we have to do bedside pericardiocentesis. So these are the atrial myxoma question, benign tumor. You can see this atrial myxoma. Okay. So this atrial myxoma question not commonly asked, but they ask from the atrial myxoma as is the benign tumor. Okay. So it can cause diastolic murmur, dyspnea, syncope, but this question they rarely ask, but some complication like by atrial myxoma, actually commonly we deal pulmonary embolism. There is a thrombus which occlude pulmonary arteries. Occlude brain stroke uncommon, peripheral arteries, blue fingers not common. So we have to make sure atrial myxoma cause pulmonary embolism. Atrial fibrillation. Atrial fibrillation question I will discuss later. Before that, because there is a question I will discuss from the atrial fibrillation variable. Just give me 1 minute and I will discuss. Dr. Vizin, are you here? Dr. Tezamul, Dr. Badhun. Okay.
Yes, ma'am.
So, Dr. Badhun, are you? Do you want to continue discussion with me?
Yes, ma'am.
So read the question. If you do wrong, it's not a problem because we are here to discuss and practice. Read the question.
Okay. A 66-year-old man present to the hospital with palpitation. An ECG taken shows atrial fibrillation. He has no history of any ischemic heart diseases. His blood pressure is 110/70. Heart rate is 130. Respiratory rate is 20. He looks sweaty on examination. His chest is clear, clinically on auscultation. What is the single most appropriate management?
Read.
I have seen heart rate is high, tachycardia. Patient is restless as he is sweaty. So to control the heart rate, I will use atrial fibrillation. Amiodarone, I will prefer.
Okay. I said if we do wrong, it's not a problem. We have to make sure. So say, Dr. Badhun, patient come to my hospital with palpitation. ECG show atrial fibrillation, right? So we have to make sure. Okay, ECG confirm AF.
Yes.
A66. Okay, A66. He has no any ischemic heart disease before. His blood pressure 110/70 and heart rate only 130. So means AF ongoing. Okay. Respiratory rate 20 and he looks sweaty on examination. Chest is clear. So single most appropriate management. So patient is man and age is 66. Single most appropriate management. This says the two type of questions. Single most appropriate management. Heart rate 130. It is not a 160. It is not a 180. Heart rate 130. But our concern to control the heart rate run. That's why you choose amiodarone. Amiodarone you choose, it will convert the rhythm and rate both. That's why you choose amiodarone because you don't know is it chronic or it is first onset. That's why you choose amiodarone. But here, these are the critical. These are the question. That's why you tested. They didn't say you are an emergency doctor. They didn't say this is the acute setting. They didn't say any clue that I have to state amiodarone right now to convert the rate and rhythm.
Yes.
I can control only rate. I can control only rate, right?
Right.
Okay. So did you get my point, Dr. Badhon?
Yes, ma'am.
So if it is emergency situation, patient with palpitation, heart rate high, and you are emergency doctor, you can say, yeah, ma'am, I will now convert the rate and rhythm because it's acute setting. But they didn't say anything. Patient present to your hospital and palpitation is show AF and it's only 130. We can make sure by control the rate only. So what is the choice of drug now?
Ma'am, I will go for metoprolol.
Okay, you will go for metoprolol. So Dr. Reza Oruzi is here.
Yeah.
Yeah. Dr. Reza, I think you already read the question, right? Or you
Yes.
want to read again?
No, I read. I know. Read
Okay,
again.
so what? So you can read again. So
Okay.
this is a very important question. Okay, you can make sure.
66-year-old man present to the hospital with palpitations. An ECG taken shows atrial fibrillation. He has no history of any ischemic heart disease. His blood pressure is 111 up 70 millimeter
mercury. Millimeter mercury. Yes.
Yeah. Her heart rate is 130 beats, and respiratory rate is 20, and he looks sweaty on examination. His chest is clear clinically on osculation. Yes, what is the single most appropriate management? I think in this case, the best is metoprolol. I read in my materials that if arterial fibrillation is with heart failure, we must use first digoxin. And if without arterial fibrillation, without heart failure, we can use for control rate, we can use metoprolol or beta blocker. If the patient is unstable and need emergency intervention, we can use electrical cardioversion with machine.
Okay, excellent, Dr. Reza. Excellent. Okay, thank you.
Thank you.
So, Dr. Badhan, your answer correct, and Dr. Reza performed well, very well. They explained that when though there is no digestion option, but he give the explanation regarding heart failure. But actually, I tried to ask a question. So I am asking Dr. Badhan, do you know
Yes,
the
ma'am.
Chadbus score?
No, ma'am, actually.
Dr. Reza, do you know the Chadbus score?
Chada score. Yeah, I know, but I can't remember.
Okay. Do you know the score in this case? Okay, no issue, because we are here to discuss. Okay, thank you. So this was the point actually I want to discuss. I will discuss later. So now explanation. I'm going towards the explanation. Exercise is the actual metaprolol, but I'm discussing in detail. First of all, I have to control the rate and rhythm. Rhythm, first of all, if it accurate setting, we can do cardioversion, but on if patient instability, but if with FVR means first ventricular rate. FVR means first ventricular rate means heart rate 180, heart rate 220. Though they don't ask you this diagnosis, they give you BP stable 110/70 and rate 220. If BP is stable, Dr. Reza, though you read from your material, but I discussed with Dr. Badhan that if BP is stable, you have to start amiodarone for cardiovert, the rate and rhythm. These are the explanation may not find your materials. You can write down, or all my candidates can write down. If BP is stable, we can make sure cardioversion by medical management. It is by amiodarone. As we already know, we can cardiovert the VT, SVT by adenosine, mainly SVT by adenosine. For AF with FVR, heart rate high, BP stable, I have to make sure cardioversion by amiodarone. But another point that Reza add, if BP unstable, it could be. I can't waste my time. We have to do cardioversion, cardiogenic shock or cardiac defibrillator machine will be there, and we can start this defibrillation by 150 joule or 200 joule. So rate control, rhythm control, both is our concern. Rhythm control metoprolol, or sorry, rate control metoprolol by rate, or calcium channel blocker, diltiazem or verapamil. We can continue digoxin if only heart failure present. Beta blocker, metoprolol, diltiazem, verapamil, all will depend. Patient is asthmatic. We can't give metoprolol. We have to start CCB, verapamil or diltiazem. Right? If patient on heart failure, we have to make sure digoxin for the rate control. Now it is common question for DHA hard exam candidates whose exam very near. They don't ask nice question. They are not asking. Nowadays our question are not so nice. But if you do practice and read and listen my words carefully, if this question I will practice with my candidate, if with heart failure, this question will be discussed with me. Dr. Fatima from UE.
Yes, ma'am.
Actually, it's my another policy. I have all other candidates from the actually Fatima little candidates. So your question, Dr. Fatima, your case and your patient is a atrial fibrillation, known common case. Okay, chronic atrial fibrillation patient develop heart failure. Exam question. Okay. Now come to your hospital and you are emergency doctor. Okay, you are an emergency doctor and you saw this heart rate is 170, okay, and patient BP is stable. How you will manage this case? Patient only on metoprolol, only on metoprolol.
Okay. Um,
If
I
you are
will give the digoxin if there is heart failure.
okay, excellent. It's a chronic case. You have to start the digoxin. Then, as
Then
heart rate higher,
I will do the cardioversion with the amiodarone.
yeah, that is the point. I can do cardioversion, but the exam question they didn't put the cardioversion option amiodarone. What they put only digoxin. That is the point. That's why I'm discussing with Dr. Fatima. The case and heart rate 170, but patient heart failure itself cause heart rate high, tachycardia. So digoxin enough. You have to mark digoxin. Question digoxin answer. And the question common recent question, AF with heart failure, control and rate is 180, 170. No need to be panic for amiodarone or whatever. As heart failure, I have to make sure by digoxin, not metoprolol. Already patient on metoprolol, right, Dr. Fatima? Okay.
Thank you.
So another question is still not ended your discussion. Another question: patient chronic heart failure, but patient didn't on Chadva score. I didn't discuss till now, but Chadva score they given Chadva score. If you don't know, no issue. Score 2 right now. Before Chadva score was not 2. Recently diagnosed as diabetes. Recently now diagnosed as Chadva score 2. How you will manage? So if heart failure, Chadva score 2, do you know the management, Dr. Fatima?
I don't know the Chadwa score, ma'am.
Okay, excellent. No issue, no issue. Anyone want to discuss with me the then he know the Chadva score, or I'll start. No issue. Okay. If Chadva score more than 1, we have to start warfarin. Okay, but sometimes even Chadva score 1, we can start in warfarin in case of female patient. Okay, but I will discuss later regarding the question. But the question answer: if Chadva score 2, patient on heart failure, how will manage? Then they give the combination of the option digoxin plus warfarin, only digoxin. What you will mark, Dr. Fatima? You have to mark digoxin plus warfarin. Clear?
Okay, ma'am.
Okay. Now Chadva score question will be come later and I will discuss later. Another question discussion. I will discuss AF, no issue. Though I didn't discuss this question just for discussion, still I didn't discuss. Dr. Kishori, KC is here. KC is maybe Kishori, I don't know. Dr. Kishore is here. Okay. Are
I'm
you
here.
here?
Yes, yes,
Yeah,
I
okay.
can.
Yeah, okay. Dr. Kishore, read the question. Though still I didn't discuss this question, but read this question and try to understand what they said.
60-year-old man had a myocardial infarction 2 weeks ago. He now presents with dyspnea and pleuritic chest pain. A pericardial friction rub was noticed on examination. ECG shows widespread ST elevation. A chest X-ray shows an enlarged globular heart. His pulse rate is 95 beats per minute and his respiratory rate is 24 beats per minute. What is the single most likely cause of this symptom? Cardiac tamponade, mitral, Dressler. I think, ma'am, this is, I've read somewhere else. Maybe this is Dressler syndrome because there is inflammation on the heart, that pericarditis. So I believe the heart tissue is damaged here. So it's a Dressler syndrome, ma'am. Just I know this.
Okay, okay. Dr. Kishore, we are here for this one. What about chest extra finding? Is it you're misguided or you are strong enough for Braziller? Would you like to change or you are strong enough for Braziller?
I think,
By
ma'am,
seeing the chest X-ray, what about that?
chest X-ray shows there is enlarged globular heart.
What does it mean? Is it efficient? What do you think?
Ma'am, it's related with pericarditis, enlarged globular heart means.
Okay. You now tell me, ma'am, this is my final answer. Just tell me.
Ma'am, I think enlarged globular heart. Ma'am, okay, you can explain.
Okay, I will explain. No issue. Because
Okay.
I want to make sure my candidates, confidence. Because it will the discussion, but we will do more wrong here, but no, not in our exam. So you can say, ma'am, this is the answer. That's it, and we will discuss more. No issue. Is it tamponade or Dresler? That's it.
It's a Dressless, ma'am.
Okay, okay, okay. Donilda, make sure. Okay, what is the answer, Donilda?
I think it's cardiac tamponade because there is enlarged globular heart. Also, there is a pleuritic chest pain, and it's occurred 2 weeks after the myocardial infarction. So it looks like a complication of myocardial infarction post sequelae. So I feel it's cardiac tamponade.
Okay. So, Dr. Nice, excellent. We done very good, Dr. Kishore strongly says that Dresler, Dr. Donilda may confuse. Is it complication? Actually, this question twisting. They nicely said pericardial friction means pericarditis, inflammation. Nicely they explained. Dr. Kishore explained nicely. It's inflammation, ma'am. 2 weeks ago heart attack, so 2 weeks ago myocarditis, inflammation ongoing cause, ma'am, there is a pleuritic chest pain, so pericardial friction rub, pleuritic chest pain. This is, ma'am, it's the inflammation ongoing. Excellent, Dr. Kishore. ECG showed widespread ST elevation in chest, to show globular heart shadow. It can be complication of inflammation of the Dresler syndrome cause pericarditis. I discussed that cardiac tamponade can be due to the pericarditis complication, but what they say, there's a single most likely cause of his symptoms. His symptoms not dyspnea, restless like cardiac JVP high, no, there's nothing, but they explain nicely Dresler, pleuritic chest pain, pericardial friction rep, 2 weeks ago myocardial infarction, though extra developing globular heart shadow, but patient still didn't develop high GVP, still didn't develop muffle heart shown, they didn't give any clue. So we have to make sure the differential point. What makes towards the my diagnosis? This is the way we do wrong in the exam. these are the two question answer. Cardiac tamponade Dresdler, and we are making this a tamponade because there's a globular heart shadow. And what are the deep is that? Deep is that there's an inflammation ongoing. So answer is Dr. Donilanda. Actually, sorry, if I
Hi, it's okay.
yeah, okay, sorry if I do
Yeah, no
wrongly.
problem.
Yeah.
No problem.
So make sure is this a complication? So we have to make sure this is the Dresdler, and this chest X-ray showing enlarged globular heart shadow. So it's a goes towards pericardial effusion, but make sure ST elevation, pericardial friction rub, all towards the pericarditis, and it developed within 2 to 6 weeks of MI. Clear, my dear candidates?
Okay, ma'am.
Excellent. So tomorrow will be long session, inshallah, from 10 p.m. And today I posted 10 question mark, and the answer will be the tomorrow morning. And tomorrow morning also cardiology question will be posted. Actually, this discussion platform, I have to make sure all are knowing well. Okay, I believe all understand the ACS management regarding the some management of the non-states, because these are the question you have to face more. Tomorrow, I'll discuss more regarding the cardiology. If I can take ECG, I can take, but if you need, I'll take another session, no issue, because cardiology, make sure the marking, definitely. Because question, we have to make sure emergency medicine question, critical care medicine question, and cardiology question. They'll give many questions. So today I am ending my session. I hope all enjoy my session today. And tomorrow we'll meet again. Thank you so everyone. Assalamualaikum. Thank you all.
Thank you, ma'am.
Thank you, dears.
Thank you,
Thank you,
ma'am.
ma'am.
Yeah, thank you, my dear
Thank you,
candidates.
ma'am. Thank you.